Welcome to Psych 6104, a biopsychosocial approach to counseling. My name is Suzanne. In this session, we will be looking at a biopsychosocial approach to treatment, specifically what it is, followed by an evaluation of how effective psychotherapy is in general. This presentation is based off of Timothy Melchert's Foundations of Professional Psychology, Chapter 10. Our outline for our time together is as follows. First, looking at a biopsychosocial approach to treatment, we will discuss what it is and things to consider. Secondly, we will answer the question, is psychotherapy effective? By evaluating whether the benefits are significant, if they last, how it compares to the use of medication, and does it work for everybody? Then we will look at the factors that account for the effectiveness of psychotherapy, concluding with a discussion on the biopsychosocial perspective on treatment. The biopsychosocial approach to treatment. What is it? A biopsychosocial approach to behavioral healthcare treatment is a holistic intervention perspective that addresses the presenting problems of the patient, builds on their existing strengths, and supports intervention in all identified areas of need biologically, psychologically, and socially. This differs from traditional methods where therapy might be provided for a specific set of problems but largely ignores additional issues. Adopting a biopsychosocial approach means a wide range of treatments and interventions are available for consideration. The biopsychosocial approach to treatment seems very intuitive in our course so far, but consider for a moment that George Engel's inaugural address regarding the biopsychosocial model was primarily directed to the profession of psychiatry. David Pilgrim reviews the past, present, and future of the biopsychosocial model in Anglo-American psychiatry and concludes that psychiatry as a profession is still firmly rooted in a biomedical model. He argues this is most demonstrated by the pervasive use of the Diagnostic Statistic Manual. Quote, DSM-3 was a landmark in the development of psychiatric classification, drawing on the best available research from the preceding decades and placing psychiatry firmly back in the medical model of basing treatment decisions on diagnosis. End quote. This is significant for psychotherapists as we will often need to collaborate with other practitioners and need to be vigilant to those supports in our patient's sphere who may not be favorable to a biopsychosocial model. A biopsychosocial focus on treatment. The biopsychosocial model of behavioral care rests on the two pillars of science and ethics. This requires ensuring the safety and effectiveness of interventions before behavioral care is provided to a patient. This includes psychotherapy. So, is psychotherapy effective? What factors might account for its effectiveness?
Simpsons? Welcome. So what brings you to family therapy?
Well, Doc, it's like this. They're all driving me crazy. I don't know what to do.
I wish I was an orphan.
Is psychotherapy effective? The efficaciousness of psychotherapy is measured by the effect size in controlled studies. The first meta-analysis of this kind was conducted by Smith and Glass in 1977, who found an effect size of 0.85. In 1984, a similar analysis conducted by Lampert and Borgen found an effect size of 0.85. Grissom concluded a size of 0.75 in 1996. Finally, Wampold determined an effect size of 0.80 in 2001. To offer a comparison, Melchert posits the effect size for antibiotic treatment of an inner ear pain in children within 2 to 7 days to be 0.07. As you can see, the effect size for psychotherapy is significant. To put it another way, a patient receiving psychotherapy is estimated to be approximately 79% better off than untreated patients, though possibly not our Simpsons family. Melchert evaluates these results through the following questions. 1. Are the benefits clinically significant? How often do patients return to normal functioning following treatment? 2. Do the benefits of psychotherapy last? 3. How does the effectiveness of psychotherapy compare with the effectiveness of psychiatric medications? 4. Does psychotherapy work for all patients? Are the benefits of psychotherapy clinically significant? How often do patients return to normal functioning following treatment? What the results of meta-analysis are showing is that approximately 3/4 of patients see a positive change as a result of psychotherapy. Furthermore, that 40 to 60% of patients return to normal functioning following intervention. But do the benefits of therapy last? In short, yes. Numerous studies that have followed patients for up to 5 years following psychotherapy have found that the treatment endures. While some studies have shown the benefits of treatment to decay over time, Multiple meta-analyses have shown the effect size to actually increase post-treatment, meaning the benefits of psychotherapy can continue to improve functioning even years following completion of treatment. What about psychotherapy compared to psychiatric medications?
Hey, Charlie, how's it going?
Boy, you really blew it this time.
Did I now? How so?
I've fallen in love with Chelsea.
Oop, my bad.
Damn right you're bad. There were plenty of medications that would have turned me into a happy little potato, but would you prescribe them? No. You said I had to get in touch with my feelings and express them to the people I care about.
Sorry, I must have been drunk.
While medication has become the frontline treatment for many mental disorders, interestingly, studies have shown psychotherapy to be equally, if not more effective in treatment for many of them. Exceptions include severe biologically based disorders like bipolar, schizophrenia, and severe depression. Why might this be? If we consider the viewpoint of a patient experiencing episodic depression or anxiety, what might be important to us in a treatment? Firstly, we would expect to have distressing symptoms alleviated. Secondly, we would not want to experience disagreeable side effects. And finally, we would hope for a treatment to prevent us from continuing to have these problems chronically, if at all possible. Medications are usually quite effective in treating our distressing symptoms. However, many are accompanied with unpleasant side effects. Secondly, when the patient stops taking their meds, symptoms can quickly reappear. Finally, medications for mental disorders are not primarily treatments for preventing the reoccurrence of these distressing symptoms. For instance, if I have an ear infection, I can take antibiotics to treat it. I'm effectively cured of it. Antidepressants taken to treat depression will not prevent depressive episodes from reoccurring. I'm not cured of it. In contrast, as we've just discussed, that the effects of psychotherapy are often enduring even post-treatment. Does psychotherapy work for all patients?
Look at him, Starling. Tell me what you see.
Well, he's a white male. Serial killers tend to hunt within their own ethnic groups. He's not a drifter. He's got his own house somewhere, not an apartment.
Why?
What he does with them takes privacy. He's in his 30s or 40s. He's got real physical strength, combined with an older man's self-control. He's cautious, precise, and he's never impulsive. He'll never stop.
Why not?
He's got a real taste for it now, and he's getting better at his work.
Not bad, Starling.
Does psychotherapy work for all patients? In short, no. However, this is not surprising. The significant number of variables in a single patient's pathology, varying in severity and complexity, are such that even the most effective therapist or medication might be unproductive. Such is the case with our serial killer Buffalo Bill. Studies have shown that the severity of psychopathology does seem to account for how quickly patients benefit from psychotherapeutic intervention. Some patients on a descending trajectory cannot be reversed, and it is a hopeful outcome of treatment to just slow the downward path. In 2006, Lampert and Archer estimated that 5 to 10% of patients actually deteriorated in treatment, while a further 15 to 25% did not improve in any measurable way. The idea that a patient can deteriorate in therapy is of particular concern to the ethics of the psychotherapy profession. The principles of non-maleficence and beneficence are foundational to healthcare treatment, and the infringement of either obligates the field to evaluate and mitigate factors contributing to the collapse of these pillars. A further consideration might be what percentage of deterioration is appropriate before psychotherapy is not considered a safe and effective treatment under the biopsychosocial model. There is also a question of the effectiveness of psychotherapy among different age groups. A meta-analysis conducted in 1987 looked at the effects on psychotherapy among children aged 4 to 12 and adolescents aged 13 to 18. After accounting for differences in gender among the sample size, they found an effect size of 0.92 in children, but only 0.58 in adolescents. The study is only one of its kind to be sure, and while it should not be taken as the last word on the matter, it should lend consideration to age as a factor in psychotherapy efficacy. What factors account for the effectiveness of psychotherapy?
So, Sheldon?
How you doing?
That's how you start a psychotherapy session. How am I doing? I was promised a riverboat journey into the jungles of my subconscious. Instead, I get the same question I hear from the lady who slices my bologna at Ralph's.
Professionals in the field have long debated the methods, techniques, and characteristics of therapists that account for psychotherapeutic effectiveness. Upon analyzing the available research at the time, in 1992, M.J. Melchert argued that 4 components that accounted for how effective psychotherapeutic treatment were the following. Number 1, specific techniques 15%, which accounts for specific treatments or techniques used for treating particular disorders. Number 2, expectancy 15%. This accounts for the expectations that a patient has regarding how effective the treatment will be. This is more commonly known as the placebo effect. Number 3, common factors, 30%. These are related to the qualities of the therapist found across therapies, such as empathy, warmth, acceptance, and encouragement to take risks. 4, extra therapeutic change, 40%. This element refers to factors associated specifically to the patient. For example, severity of pathology, level of patient's ego, or the patient's environment. This could include basic needs, the availability of social supports, and many other determinants across the biopsychosocial sphere. However, in 2001, Wempold's analysis argued that 70% of psychotherapy effectiveness was dependent on the competence of the therapist. He further postulated that less than 10% accounted for specific techniques or therapies, with the remainder accounting for patient characteristics. More and more research is lending evidence to this theory. So just how important are the skills of the individual therapist in explaining therapy effectiveness? First and foremost, therapeutic intervention is one of relationship. Ultimately, the therapist is the architect of that connection. A 1996 study by the National Institute of Mental Health showed that the quality of the therapeutic alliance was the most important factor explaining improvements in patients' depression in both psychotherapy and pharmacotherapy conditions.
It's so right that you and I have come together, isn't it, Dr. Marvin? I know it was meant to be.
You think so, Bob?
Yes. Because it's time, and I'm ready. With Dr. Carswell Fenstewald, I wasn't ready. With Dr. Rosengay and Franceschi, it wasn't time. I certainly wasn't ready for Mallerstein or Miller or Hill. But with you, finally, I'm ready.
In 1994, Arnold A. Lazarus wrote a fairly controversial article arguing that some of the limits imposed on therapists actually impede their ability to build productive relationships with their patients, ultimately limiting the effectiveness of therapy. While certain behaviors would no longer at all be tolerated, like playing tennis with a client, he makes a solid case for the removal of excessive boundaries. Simple things like insistence on diverting any personal questions, no matter how insignificant, he argues builds a demeaning and hostile environment with the patient. Instead of hiding behind rigid boundaries, he advocates for practicing psychotherapy responsibly, with compassion, benevolence, sensitivity, and caring. Undeniably, it is up to the therapist to navigate the boundaries and dynamics of the rapport towards the most successful outcome. The next consideration is what qualities a therapist needs to have to build that effective alliance. Horvath and Betty concluded in their 2002 study that there are 3 categories of such qualities: interpersonal, intrapersonal, and interactive. Melchert's text described these components very concisely as, quote, an interpersonal skills component relates to a therapist's ability to respond sensitively to patients' needs, maintain open and clear communication, and communicate empathy and openness. It also includes avoiding taking too much control, offering interpretations prematurely, or being irritable. An intrapersonal component refers to negative and hostile therapist behaviors and dysfunctional personality characteristics, while the third component refers to the ability to develop a collaborative relationship with patients. End quote. This evidence is supported by a review on research conducted by Lafferty and Butler in 1989 that concluded, quote, variables that are specific to or are developed within a given treatment relationship are more potent in determining outcome than are global variables such as therapeutic orientation or demographic background, end quote. A therapist's level of empathy was considered a significant factor in the effectiveness of therapy. An interesting discovery of their research found that less effective therapists placed emphasis on living a comfortable, prosperous, and exciting personal life, contrasted with more effective therapists who tended to place significantly more importance on intelligence. I think the takeaway from this is not that one has to value intelligence to be an effective counselor, rather to raise awareness about how our personal value sets may influence our effectiveness as therapists. With this evidence in mind, can the number of treatment failures be reduced? There is a very simple method for reducing treatment failures in psychotherapy. Ask patients how they are doing. Obtaining patient feedback is becoming increasingly common. Some of you may have experienced this yourselves or conducted this method in your own workplaces. Patients are often given a questionnaire or survey prior to a session or treatment, and again at the end. If the treatment is ongoing, there are often points mid-intervention where client feedback is obtained. This allows for adjustments to be made to realize best possible outcomes. A biopsychosocial perspective on treatment. We've spent some time discussing whether psychotherapy is an effective intervention and what makes it so. But what does this mean for our discussion on a biopsychosocial perspective on treatment? The biopsychosocial approach extends beyond the borders of individual therapy and invites a complete, holistic, integrative approach. This equates to broader case conceptualization, resulting in more treatment and intervention methods available, which requires a wider network of professionals to be collaborating to meet the biopsychosocial needs of the patient. Furthermore, with an increased focus on the behavioral health and biopsychosocial needs of patients, more emphasis is being placed on treatment outcomes. This has resulted in more systematic monitoring of interventions than in traditional methods and will actually be a focus of a future topic in this course. To give you an idea of how the biopsychosocial model affects treatment outcomes, consider the example asserted by Len Sperry in his study of chronic illness. He compares the biomedical model, the psychosocial model, and the biopsychosocial model. Quotes, in the integrated biopsychosocial model, psychosocial stressors do not influence chronic disease activity directly, but rather indirectly, through a cycle of psychosocial responses which either reduce or exacerbate the effects of the psychosocial stressors on the disease. The biopsychosocial model offers a comprehensive perspective for assessing and treating chronic illness. End quote. So as you can see in his adaptation of the biopsychosocial model, it recognizes the ongoing interactive relationship between multiple factors of human functioning, introducing multiple points for possible intervention. Broadening of case conceptualization. The biopsychosocial approach to treatment opens the doors to consider any and all factors in the patient's life that are impeding or facilitating their functioning. In previous weeks, we have discussed the common biopsychosocial concerns in the populace, many of which have etiology and/or impacts in additional domains. For instance, people who experience chronic pain might also experience obesity, stemming from childhood maltreatment. It may impact their current ability to work, parent, or otherwise participate in society effectively, potentially having impacts on their financial stability and mental health. As we can recall from our previous discussions, the biopsychosocial approach also looks to evaluate areas of patient wellness and strengths that can be fortified to bolster treatment outcomes and build resiliency. In short, the biopsychosocial approach is constantly evaluating what else. It looks to build the most comprehensive blueprint possible of a patient's existing psychopathology, etiology, long-term care needs, and sources of strength. Broadening of treatment options. With that exhaustive blueprint in place, treatment options can seem near limitless. While individual therapists are learning new techniques and methods all the time, some even practicing psychopharmacology, the range of options available to meet the complexity and severity of a patient's needs often extend beyond the reach of a single person's capabilities. Collaboration. Melchert postulates, quote, as the level of care increases, the number of different types of professionals and third parties involved tends to increase, and the level of collaboration needed to effectively provide the care increases as well. End quote.
Could be lymphoma.
Not with normal LDH.
ITP fits, we should start her on methotrexate.
Absolutely. And total body irradiation.
Because she failed the bleeding time test?
TBI will promote cancers, kill her digestive tract.
Don't forget, stop her from bleeding into her brain.
It's premature, reckless, and potentially lethal.
True. Must be somebody's job to stop me from being reckless and irresponsible. Nobody can stop me from being premature.
One therapist cannot reasonably meet all of the biopsychosocial needs of a single patient. They may treat a brief problem and then refer the patient to or collaborate with other healthcare providers to implement other necessary interventions. This is referred to as a graduated or stepped model to treatment. Working from the biopsychosocial perspective, you can expect to include or collaborate with any or all of the following: family members, educators, employers, friends and/or other important persons in the patient's life. These collaborative needs should further remind us how important the therapist's effectiveness is. A counselor who has honed the qualities and skills needed to build effective patient relationships will likely play a key role in orchestrating a team that can work together to meet the biopsychosocial needs of the patient. Concluding thoughts. In this session, we have discussed the biopsychosocial approach to treatment, whether psychotherapy is effective, and what factors make it so. We have discussed whether the benefits of psychotherapy are significant, if they last, how psychotherapy compares to the use of medications, and whether therapy works for everyone. Finally, we have reviewed how psychotherapy fits into the biopsychosocial model of treatment, how that affects case conceptualization, treatment options, and multidisciplinary patient teams. Obviously, the constraints of the presentation prevent us from discussing every relevant aspect of these topics. Therefore, I invite you to review any of the references provided below and address any questions or points for discussion to the forum.